Hi everyone. Decided to do up a short talk on the PACES Station 2 exam um, because somehow it feels like this is one of the more neglected stations in candidates' preparation efforts. So an overview, this is the history-taking station that is 20 minutes long, of which 14 minutes is allowed for history taking, followed by 1 minute of reflection and a 5-minute discussion with the examiner. Of note, there's a change in the format come probably 2021, where the examination board recognizes that for Station 2, the construct is quite artificial because it's only history taking with no contextualization for physical examination and investigations. And then the Station 5 is more realistic but very time pressured. Hence, the new consultation format will be two 20-minute stations, for which 15 minutes will be allowed for history taking, examination of the patient, and subsequent discussion. I think in light of this context, one must then take a step back and recognize that the Station 2 really isn't a long Station 5 per se, which if one goes in with a typical Station 5 mindset, one may struggle to do well in the Station 2, like what happened to me in my own exam. So I'd like to talk about 3 points. The first point about Station 2 is that of broad differentials. So the cases that are carved out in Station 2 are intentionally vague in the sense that even after you've gone through the whole history, there may not be a single resounding diagnosis that ties everything in. Patients oftentimes will have symptoms that may have multiple features that can point in different directions. They may have risk factors for various differentials, and hence your task really is to explore these differentials laterally. And given that there is a significant amount of time, one also then would have to take a proper systematic review to then tie these various clues that you get into different pockets of differentials. This is quite unlike the Station 5, where oftentimes you may end up with one or two very likely diagnoses that ties everything in. And this leads to the second point about tunneling. While generally in medicine it is not advisable to tunnel, but in the Station 5, in its current form, to some extent also, it is quite an artificial construct where normally you have a background condition with an acute presenting complaint, and the acute presenting complaint, the diagnosis that is intended is contextualized to that background underlying condition. So for example, a patient comes in with shortness of breath in the background of, let's say, some autoimmune disorder like ankylosing spondylitis, and that shortness of breath is due to interstitial lung disease. So one is supposed to make that connection, and to some extent that tunneling, yes, with a fair share of sound differentials, will be helpful in the Station 5 exam. But in the Station 2, tunneling is going to be problematic because, number one, the cases, as mentioned, are sometimes fairly vague, and the intention really is to consider various differentials, and sometimes the weightage of these differentials would not be as distinct as Station 5, where there's one clear likely differential and the others rank much lower down. So for Station 2, once you have your multiple differentials, the task is about ranking these differentials and not about dismissing differentials at the outset. So I would advise against tunneling, and I think it's something that I did in my own exam and hence didn't do too well. And the third and final point is about planning your physical examination investigation requests as you go along. And the reason for this is because, as mentioned, oftentimes in the Station 2 exam, you may end up having 4 or 5 differential diagnoses. And what can get quite challenging is when you come to the discussion period, and when in the midst of the exam stress, you may not be able to systematically list down what you want to examine for and what are the investigations you like to send off. And in doing so, if you have an important differential and a key test was not listed, then one may be faulted. So for example, the case that I got for my exam was a patient who came in with some form of altered mental status on the background of multiple medications, some psychiatric disorders, at the same time also on anticoagulation, and the differentials were quite wide-ranging, from that of intracranial bleed to medication side effects to possible overdose. And one of the things I missed out was a toxicology screen, because yes, it was under my list of differentials, but what I failed to do was to actually plan systematically what each differential would correspond to in terms of physical examination investigations. So I think this is good practice to incorporate into your preparation, and I think it's something that would be able to help you do better this station. Yep. So I've come to the end of this short presentation. I think the take-home points are that Station 2 really isn't along Station 5. Cast a broad set of differentials, avoid tunneling, and plan in terms of the investigations and physical examination that you want to do. Thank you.